Good evening, everyone, and welcome to Woo You. We are live with Dr. Jordan Dow. Thank you so much, Dr. Dow, for being here with us. And thank you to everyone for making Woo You part of your Thursday evening. Next slide. I'm your host, Elise Kramer, currently in Miami. Where are you from, Dr. Dow?
I am in Jacksonville, Florida.
Oh, not far, not far, not
Ah, not
far.
far at all.
Next slide. All right, so thank you to Revital Vision for exhibiting at this event. And just a few housekeeping items before we begin. This is a 1 hour CE course, so attendees must be online for a minimum of 50 minutes in order to obtain their credit. For a COPE certificate, there will be a survey link in the chat. You'll also see that link toward the end of the webinar. You'll be receiving your certificates via email. They'll also be sent to Arbo with OE tracker numbers on your behalf. But there's also going to be a QR code at the end of the event. So if you have the OE tracker app on your phone, you can get instant CE, but you do need the OE tracker app. It will not work with the regular camera on your smartphone. If you don't have the OE tracker app, it's not a big deal. You'll still get your CE certificates via email within about 4 weeks. You can ask questions to our wonderful speaker here by using the Zoom on-screen floating panel that you can see below. We're going to be looking at the Q&A only for the speaker. If you have any questions for our staff or anything glitching on your end, you can just write that in the chat there on the left. Next slide. And if you're connecting from the mobile version tonight, you can find that Q&A at the top for our speaker. And if you want to go to the chat, you'll see those three dots at the bottom. Click there for more options. Next slide. And without further ado, I will introduce our speaker. Born and raised in Lincoln, Nebraska, Dr. Jordan Dow graduated from the University of Nebraska in engineering, went on to earn his Doctor of Optometry degree from the Southern College of Optometry in 2015. Dr. Dow founding Dow Family Eye Care in 2017 in Jacksonville, Florida. In his family-focused practice, he has a deep passion for innovation, technology, and patient education, with specialty offerings including myopia management, specialty contact lenses, IPL, radio frequency, vision therapy, neurovisual medicine, and vital vision. He ensures his patients have access to the best in modern eye care. Beyond the Exam Room is on the board of the Northeast Florida Optometric Association, is a member of the American Optometric Association, is the Vision Source Administrator for Northeast Florida, and is the founder of Specialized Consulting, where he is a KOL speaker and consultant to help other practices grow and implement specialty services. Outside of work, he has a wide variety of hobbies, but will forever cheer on his corn huskers, but is slowly learning to tolerate the SEC. Most of all, he is a devoted father to his two young daughters and spends every free moment he can with them. Do you have any time to sleep, Dr. Dow?
I don't sleep much. It's fine.
All right, take it away. I'll be on later for questions.
All right, sounds great. Yep, financial disclosures right here. Some of my history as KOL, and some of the consulting that I've done. But thank you guys for joining me. This is a little bit of a more dense of a topic, and so before I get too far in this, I just want to say again, thank you. Hang with me. You know, this is a little bit different than a lot of our normal CE. But also, I welcome further conversations about this. You know, reach out to me. We'll have my contact information at the end. Every time I do one of these talks, I'm learning more about it as well. And so really do welcome further discussions in this, as this is a very new technology in our field, which is a very cool thing to see. A little bit more about myself. You know, again, this is nothing that we haven't already said already, but you know, I graduated from SCO in 2015. You know, I'm a private practice doc and have two locations. And that's started up cold in 2017. We do a little bit of everything. Really emphasis on specialties and technology. We're ranging from myopia management to vision therapy and dry eye stuff. But you know, really, I've spent a lot more time with my girls, and so 4 and 7 recently turned both of those ages, and they're already little divas. So that's where my little sleep good disappears. And so here are some of my disclosures again for Vital Vision, an advisor and a KOL. Nothing else there, but let's get into it. Neuroplasticity is going to be the first thing we're going to talk about. So stop me if you heard this one before, but patient walks into a room and says that they have blurred vision. Really, that's our job. That's our bread and butter, but what causes blurry vision? It can be refractive error, ocular disease, cataracts. There's honestly a million of possibilities of what they could have that could be causing the blurry vision, and it's our job to figure it out. And so, what is vision? What is the visual process? Let's go real bare bones and break it up into two different parts. Part one is the optical portion, the image capturing. This is the front half. This is the eyeball. And that's what we are obviously a lot more familiar with. We're going to have everything from the cornea to axial length, all, factoring into this part of the vision. And then we have the neural part, the image processing, the back part of vision, and this is the brain. As eye care practitioners, we do primarily focus on the front parts. We're great at working on eyeballs, doing glasses, contacts, disease management, and we really are fantastic at this. That's what we do. However, what do we do when fixing the eye isn't enough? Is there a way that we can optimize the image processing part of vision? And really, when we know that the visual or that the cortex is involved in up to 50% of visual function, 50% of the cortex is involved in visual function, we really should be looking at how can we improve the back part as well. And so, holding on a second, this is something where, we should be able to do because the brain stops development in childhood. That's, after all, what we learned in school, right? That's what I learned. But, some of the things we learn in school doesn't always stay. I will forever think of Pluto as a planet, but my kids already tell me I'm wrong. And so, looking at neuroplasticity, getting past that, neuroplasticity is basically the way for the brain, the nervous system to adapt and change in conditions, acquire new skills, and grow and learn. We typically attribute this with kids, younger as they're developing. However, there is some newer evidence that's showing that neuroplasticity is going beyond that critical age of, 7, 8, 9 years old. And we have adults visually that are getting improvement in vision from, patching or from necessity because their good eye gets lost by injury or disease or something. And so here's a case in point right here. This is a meta-analysis that includes multiple studies with 254 individuals, all of them over 11 years old, all of them having amblyopia in one eye with no disease in the other eye. And for whatever reason, they lost their vision in the good eye, were left with the amblyopic eye. And just simply by living life, 10% improved vision in the amblyopic eye. This shows some, limited neuroplasticity even in adults. And so kind of, doubling down on this, we have this study here where we're showing two groups. Group A is one that has their glasses, contacts, whatever, but also are doing patching with near activities. And the second group is just doing glasses. And we have a few different age groups here. And so the interesting thing to note here is, we're getting a little bit of improvement in all of them that are doing the patching. However, when we're looking at how much the patching is helping, the younger crowd at 7 to 12 years old and the older crowd at 13 to 17 actually have virtually the same amount of improvements. And so that's something that kind of goes in the face of what we were taught originally. And now we are saying that there is a limited neuroplasticity. So how do we use that? How do we use that limited neuroplasticity to actually improve vision in adults? And that's what we call perceptual learning. What is perceptual learning? Repetitive exposure to a very specific stimulus that improves neurological function. We're taking advantage of neuroplasticity by teaching the brain to do something better. We're teaching an old dog new tricks. There's lots of studies out here to support that this is a thing, that this is something that we're learning more and more and more about. And so, starting at kind of the base of this, let's talk about the Gabor patch. The Gabor patch is basically this representation of it's a pattern. It's this alternating white and black lines that I know we've seen going back to school. And it's basically the shape of the receptive fields in neurons in the visual cortex. And so being able to show this basically gives us a stimulus that basically is shown in brain activity. We know this because we had a wonderful cat experiment once upon a time where we put some electrodes attached them to a cat and had them look at a stimulus projected on a screen. And we're able to actually identify different neurons reacting to the stimulus. And what we found was each individual neuron reacted to a very specific stimulus. in such a way that it taught us how the neurons actually are working and working together. So whenever we want to learn more about neurons, we just have to go ahead and plug in the cat, I guess. But in this experiment, again, we had individual neurons. We were able to identify that each one responded to a precise location, orientation, and a spatial frequency. And when we're actually looking at multiple of these individual neurons with all these, specific things working together, that's what created the image that we actually see. And that's the visual processing is actually the cooperation of multiple of these neurons working together. And so, what makes it so that things are blurry? Well, we have this visual crowding. When we have an image, we have a target, and yet we put all this other junk around it, and it makes it so that we can't distinguish the original target anymore. It gets lost in all the noise. And so this is something that is going to have a very poor signal to noise ratio. And so some examples of visual crowding right here. If I told you to look for the six, you could very easily find it on the right, but in the left, even though I have an arrow pointing to it, it probably takes you a second to confirm, yes, that is a six. How many of you remember this from when you were a kid? We're looking for the guy in glasses and a red and white sweater and hats. That should be a very easy thing to find. And yet it takes you a while to find him, even though he's right there smack dab in the middle because of all the noise in the picture. This is something where our brain knows what we're looking for, and so we have a hard time finding it because of everything that is going on around it. How about right here? How many of you see the kid in the streets right here? But how many of you see the kid right here? And so this image right here, this is something that's very important because we have a target that we're looking for, but it's getting lost in the noise. This is a perfect example of that visual crowding, and more specifically, lateral masking we can use here. This is a very specific type of crowding where we can actually take a target and surround it by what are called flanking targets. And by crowding it with those flankers, we can actually exhibit some excitation or inhibition to the neuron itself. And so by using this target, flanking it with the flankers, we can actually change the neuron response. That's a bit right there, but right here, when we're showing this image where we have our target surrounded by two flankers, you start learning to look for the target. That's what this means. And so now if we go back to this image, how many of you are able to see that target now? Now that you know what to look for, now that you know what the noise is, you can see right through it, and you've already learned to look for that target. And so, looking at this experiment, going back to the cats, plugging them back in, we have this very simple line that's showing that at a low contrast sensitivity, we're getting a limited response. As we increase the contrast of this target, all of a sudden we're getting a more and more and more of a response. That makes sense. The more definition, the more contrast we have, the easier it is to see a target. What's interesting in the second part of this is when you actually put that target around flankers. And by putting the flankers in there with the target, you are seeing an increased neuron response at the lower contrast. And as the contrast goes up, you're getting even more and more of a response. And then there comes a point where the target is actually as high of a contrast as the flankers, and you end up getting an inhibition as well. And so this is the basis of everything that we're talking about is we're going to have this basically whole program set up around the fact that having that target in the middle surrounded by flankers is going to give us more of a response. This shows that the target by itself does give a limited response. Flankers by itself doesn't give any response. But when you combine the two, you're going to get a massively different neuronal response, which we can use. So how do we use it? What if we apply this flank stimulus to, let's say, a deficient neuron, a neuron that does not work the way that it's supposed to? Well, let's go ahead and take a small nail. Let's hit it with a big old hammer. Let's say the big hammer is this Gabor patch with flankers, with that target in the middle, and that small nail is a deficient neuron. And let's just go ahead and keep on banging on that deficient neuron and banging it over and over and over again. And that, my friends, is perceptual learning. And so when we have this idea of perceptual learning, how do we actually make a program out of this? The first part of it is going to be identifying where the neurons are going bad. What is the cause of the cortical blur? Again, like we said before, there's 1,000 different things that we can do. Amblyopia is more of a neuronal development kind of a blur. We have refractive blur caused by myopia and presbyopia and these kinds of things. Corneal stuff, everything from disease or trauma, keratoconus, that's going to create a different kind of blur. Retinal irregularities. And what about night vision? The night blindness where we're talking about glares and poor quality of vision with reduced contrast sensitivity. All those are different types of blur. But the thing is with each of these types of blur, they all relate to a specific neuron that is deficient, that is not being able to pick up the right image. And so determining this causality really lays the groundwork for everything that we're trying to do here in improving the neuronal response. And so because of that, because of this relationship, we can actually take a patient and test their visual threshold for a very specific neuron by showing them a specific stimulus. An astigmatic amblyope who has basically the neuron that is responsible for creating a sharp image at a very specific axis of the astigmatism that was never developed and they have a hard time with it. And we can give them a visual threshold test to see how much it actually takes for them to be able to see through that and identify how deficient the neuron actually is. So once we identify that there is a deficient neuron, now we can try to find a way to match it with a very specific stimulus. So there's a lot of different types of stimuli that we can do, a lot of different manipulation we can do. We can change the spatial frequency or the orientation of it, the size and the contrast. When we add the flankers in there, we can change the orientation of the flankers. We can separate them or get them closer, or we can change the alignment of them. And they all give different responses. Every single combination of stimuli actually matches a defective neuron that we've identified in the cortex. And so we can create a software that takes advantage of this, and it can basically take all of this information and create a program where we can identify the blur, we can identify the matching stimuli that we need to address it, and create a program to improve this. Again, taking that astigmatic amblyope, and if we're trying to improve that, that vision, we can, identify the stimulus that is required to stimulate that very specific blur point from the astigmatism. And so every patient ends up having a very customized sensitivity profile for their neurons, and everyone sees things slightly differently. And so we just are able to match that up by knowing the target's stimuli. So we have found what is causing the blur. We have found a matching stimulus that corresponds to that neuron that's not working. And so now we can use the Gabor patches with the lateral masking to basically establish where the patient is on the threshold. So right here we have a target, Gabor patch with flankers. All right. And then that's basically the yes target. This is the thing we want the patient to look at. But if we actually give them two different displays and we flash one and then we flash the other in a random order, and one of them has a target, one of them does not, well, the first, they have to identify which one had the real target. And if it was the first image, they press the left mouse button. If it's the second image, they press the right mouse button. And the system takes that response and provides feedback to it. And we're able to keep on repeating this and use this staircase approach where every time they get it right, it gets harder and harder and harder. And then when they get it wrong, it goes down. And so we have this up and down staircase that we're basically finding the point that a patient's visual threshold is. And that's where we can decide if a neuron is defective or not. So now that we've actually kind of established where the patient is after identifying the blur and the matching stimulus, now we can go and have fun. Now we can go ahead and just, use that hammer and keep on banging that neuron that we've identified and keep on forming new connections by repeated stimulus. And then the more we do that, the more we can create these neuronal connections, and it creates a permanent improvement to how the brain functions. It can help vision permanently. And so another way of looking at this, we're talking about neurons, we're talking about, stimulus. There's a lot of this technical stuff out there, but what does it actually mean for our patients? Well, when we repeatedly stimulate a neuron, and we are basically promoting the spatial interactions between them, and we're improving that signal to noise ratio. We're making it so it's easier to identify the targets. And so that improves contrast sensitivity. All right. Contrast sensitivity being the ability to distinguish details in the background. right? If we improve contrast sensitivity, we then improve visual acuity. And then by improving visual acuity, we then can make a further jump and say we're improving depth perception, stereopsis. And so what makes this effective? Really, there is the intensity of the visual stimulus. We can use the lateral masking technique to bait with the Gabor patches to give us something that's really worth looking at. We can match that very specific stimulus to the neuron and know what we're doing when we're actually providing that certain stimulus, what neuron we're trying to fix. And then we can go ahead and change the contrast level to get to this point where we're in this blue zone where we're actually causing growth. We're causing excitation, a greater neuronal response than what we would have normally to improve the vision in that particular neuron. And so that's all the science. It sounds good. It sounds optimistic, but how effective is it actually? Well, there's lots of studies out there. We have about 30 clinical studies that have been published, a little bit more than that at this point, many of them in scientific journals and whatnot. But let's start with the big one, the where it all started. This is amblyopia. And so there's a ton of studies out there on this, all showing good results, but let's break it down a little bit more right here in this random control study. First off, looking at the average age. We're talking about a 35, 38-year-old in treatment group, placebo groups, respectively. Before the treatment, they were about even at an average of 2050. Okay. After the treatment group improved about 2 lines down to 2030, while the placebo group stayed the exact same. And even more impressively, the treatment group actually stayed that way. They kept that improvement for a whole year afterwards. Here's a bar graph, or here's a graph representing that. This is a contrast sensitivity graph. And so we can see here the spatial frequencies. Very important that we have those 5 points down there of different spatial frequencies. And we can see that at all spatial frequencies, before treatment, they were reduced. They were lower than what they should be. But then at the end of treatment, we actually got an increase in contrast sensitivity in all points. In fact, it was actually 100% improvement in contrast sensitivity. And even more impressive, 12 months after the treatment, it was actually the same or even a little bit better than it was directly after the treatment, showing that the changes that we made in the brain, the changes that we made in the vision perceived by the brain was a permanent change. And so here's a little bit more of a breakdown of the patients that were here. And so we would expect that the younger folk would have a better response. But if we're looking right here at all the older folk that are well past the critical age for vision development, we're even seeing these 41 to 55-year-olds that are getting 2.5 lines of improvements over the course of this training. And these are amblyopes. These are patients that an amblyope walks into your office and their vision is blurry. You have nothing for them. Except now, this is something that is showing patients with that amblyopia at 40, 50 years old are getting 2.5 lines of improvement by going through this training. Very, very interesting. Now, we also take that extra leap to depth perception, stereo acuity. And so right here, the green is before training, the red is after training. And so really looking at the fun part right here, where we're seeing how the purple bars are all higher than the green bars. We are showing improvement in stereo acuity in the patients from this study. And then a step further and actually looking at binocularity using both eyes at the same time. Before the training, there was a whole lot of suppression and only a little bit of fusion. And then we look at the end over here and we're seeing how much more purple, how many people gained fusion after this. People who could not fuse before the training and afterwards could then fuse eyes. That is awesome. So the best part about it is again, this 5 year long follow-up study where it actually showed that patients that started out before the treatment in this study were 2070, again, average age of about 25, and then, or all over the place. And then, after 5 years after the training, they were still holding on to a 2040 vision, two and a half to 3 line improvement in acuity from when they started. So this is showing longevity. This is showing permanence. A little bit more in the amblyopia field. We're talking about albinism and bilateral amblyopia in the treatment group versus the control group. The control group really didn't have bad vision at all. They were great. The treatment group definitely had reduced vision, and you see the improvement that we had in the treatment group. While the control group really was about the same. And again, improvement of 2.1 logmar, that's 2 lines of acuity improvements in patients with ocular albinism and bilateral amblyopia. Again, something that traditionally we just look at and say we can't fix it, and now here's a way to improve it. In the same vein, we have nystagmus. And in this one, again, a few little points here. Best corrected acuity between 2040, 2200. And then at the end of this 4 months, 60 training sessions, we had an improvement at near acuity of 2 lines. We had an improvement in distance acuity of over 1 line. We had improved visual function in 23% of patients, and 88% of patients gained binocular vision, patients with nystagmus. All right. So just kind of think about your patients with that have nystagmus about gaining binocularity when they didn't before. Now, shifting gears a little bit, let's talk about keratoconus a little. Keratoconus, vision improvement in keratoconic patients with perceptual learning. This is another area where we've seen something. And so this is a study where we had a bunch of people in treatment and placebo groups, and looking here at the treatment group, we have almost a 2 line improvement in this study on average across all the patients. And then we had improved stereo acuity, we had improved contrast sensitivity, and then when you look at the placebo group, virtually no improvement whatsoever across the board. And so this is clearly doing something for patients with keratoconus as well. But here's another study showing keratoconus, in case that was a one-off, and these are actually stable keratoconic patients, patients who have already had corneal cross-linking. We've already fixed these patients. There's no more that we can do, and their best corrected visual acuity is 20/40 or worse. Going through 40 training sessions over a 3-month period, they actually got an average 2.5 lines of acuity improvements, knocking them from 20/40 to what, 20/20, 20/25, which is a huge difference for these patients, and improve contrast sensitivity. So, again, thinking about your patients in your office, what if you just consider this as something to do as a vision enhancement after a surgery? It could really change how people's recovery time and experience of vision after surgery are. But let's hold on a little bit. We're talking about disease. We were just talking about neurons and things like that. The neurons are not deficient here. The problem is the cornea, right? Well, the corneal irregularity caused by the keratoconus is causing a scattered image on the retina because it can't focus light onto a point on the retina. So we're having to utilize more neurons in a pattern that's very atypical of how they basically developed during childhood. And so even though the neurons are not deficient, perceptual learning can actually reteach these neurons to process this new pattern that's caused by the light scattering. And so think of it like if ever you have the misfortune of having to break your dominant hand, and you have to use your offhand for a period of time, you get better at it. Through repetition, you become better and better and better with your offhand, and to the point where when you actually go back to using your dominant hand again, it almost feels like it's the worse hand because of that. That is repetition and learning. And so, in the same way, we can actually take the clear portion of this image, enhance it while cleaning up the blurry parts, and this leads to processing an enhanced and refined image, despite the fact that the blurriness was caused by an ocular disease versus a development problem. And so let's go ahead and jump on that train of ocular disease and look at cataracts, post-cataract surgery. Patients that actually are seeing pretty well, 20/30 or better, best corrected, 20/20, 20/50, a lot of these good numbers, these aren't blind patients, but their contrast sensitivity is way below normal. And if you've seen these patients where they're coming in and they're reading 20/20, but they're insisting that their vision quality is poor and they can't see anything, and it's frustrating because we don't know how to help them. Well, these patients, we sent them with basically 20 or 30 at-home training sessions during a 2-month period, and these are the results of the control group. First, we're showing basically no change in contrast sensitivity. They were the same from day one to 2 months later. But in the treatment group, they actually showed an 83% improvement in contrast sensitivity over the course of the training, right? 83%. That's almost doubling their contrast sensitivity function. And then not only that, how does that relate to acuity? Well, it ends up being 2.5 lines of improvement in acuity for these patients that, were struggling. And so we're talking improved contrast sensitivity, improved acuity. It's really, really a cool thing to be able to do this for patients when before, again, we could not really help them. Macular degeneration, this is another disease that can really debilitate patients. And in the couple of these studies that they've had out there, just summarizing it, about an acuity improvement of about, almost zero point 0.3. That's a 3 line improvement in acuity in these patients, and it maintained stable for up to 6 months afterwards. So, shifting gears a little bit, we have all these things causing blurry image. What about myopia? All right, keep it simple, right? Well, look at the average age. We have 34 years old, and these patients were all about 1 diopter myopic in the treatment group. And when we're looking at their acuity before the treatment, it was about 20/40. Acuity after treatment was about 20/25. Again, getting that same 2.5 line improvements, and again holding steady a whole year after the treatment. And so, why are we making this shift? We're fixing refractive error. We were just talking about diseases and stuff. And so, neurons are not deficient in this case. There's nothing that's creating an irregular image from a disease, and glasses fix it. Glasses make it all better. But when we're not wearing glasses, the light's not focused on the retina. We're still getting a blurred image. And it's the same thing as when we have an ocular disease where the neurons aren't getting the right, basically reception in order to see clearly. And, we can teach the neurons that receiving the blurred image is okay. We can clean it up and we can process a clear image out of the blurry one. We may not be able to completely correct for large refractive errors, but we can actually help the brain to learn to process through about 1 diopter of blur into a clear image. It's like taking a picture and then going through Photoshop and clicking the enhance button. It can clean up the image for us. And so let's take that and go on to presbyopia. And, average age, obviously 46, an add of about a 1.4. These are acuities that are unaided at near about 20/40, and then we're still getting an improvement of 20/30 that's holding strong for 6 months at a time, even after they've, gotten older by 6 months, and we expect things to be getting worse. They're actually getting better. And then moving on again even further, let's go even more subtle on the blur. Let's talk about these athletes. Let's talk about sports vision. This is actually from the standard league out in Europe, and a soccer team out there where their acuity is great. They're already very high performers, and they're seeing 20/25 or better through their habitual correction. And still putting them through these 30 training sessions over the course of 2 months gave us this. Now we're getting an acuity improvement of, 2020 down to 2015, 2018 to 2016. Not really a big difference there, but look at this. The contrast sensitivity improved 87% in the treatment group. Imagine yourself as a baseball player needing to hit a baseball under the lights. How much help would it be if you could just be able to distinguish the details of that ball coming at you 100 miles an hour and tell where the laces are so you know what kind of pitch it is? This could totally change how an athlete is able to perform. And there are other studies out here. There's things from LASIK to, RP and colobomas, and feel free to look those up. But across the board, we're seeing the same consistent improvement in contrast sensitivity and acuity about 2.5 lines. So that is where we're at with the perceptual learning. All right. That is what we're talking about. So what about the patient experience? This is something that we, prescribe to patients and they go through and they get this improvement. And it starts with a comprehensive exam. Um, where we really need information to establish the beginning of the program. And we also identify the goal. There's a lot of different things that we're looking at here. And so being able to pin down the exact etiology and the goals of what we're trying to accomplish modifies the program of what we're trying to do. You're going to need to do a couple of different tests during it, but this is not much different than what we're doing during a standard comprehensive exam anyway. We're already taking acuities and refraction. Binocularity, maybe not in every single patient in a lot of cases, maybe sometimes we do, but this is very easy and very quick that we can do. And contrast sensitivity, a little bit tougher. And it's not required, but if possible, this is also very helpful to be able to track improvement for patients and quality of vision. Once we do prescribe this to a patient, And yes, we prescribe this to a patient. They basically are able to take it home and perform it on their own computer. They don't have to come into the office, which is nice because we're talking about 3 to 4 sessions per week, each session being about 30 or 40 minutes long. And so that ends up being that we're doing 30 or 40 sessions over the course of a 2, 3 month period. That's a lot. And so patients being able to do this from the comfort of their own home is easier on the patient and easier for us as eye care professionals taking care of them. And so the treatment flow really overall looks like this in a controlled environment. Let's say we have a patient doing 40 sessions, 30 minutes each, doing about 3 or 4 sessions a week. And as they're doing these sessions, it's feeding the results into a data center, and the patients are able to actually watch their progress and how they're performing on these tests. And of course, we can too. We can monitor the portal and see how they're doing. And then if we're checking their vision every month or so, their acuity, their depth, their contrast sensitivity, we're going to keep on seeing this improvement. And then once the acuity plateaus at about that 30 or 40 sessions, well, then we're over. Then we're done, and the patient actually has a permanent improvement to their vision for their basically we can assume the rest of their life. And what sort of improvements are we getting? Again, just as a reminder, for contrast sensitivity, we're expecting on average a 100% improvement in contrast sensitivity. That's doubling their contrast sensitivity. We're expecting about a 2, 2.5 lines improvement in visual acuity. That's something that is done by training, and that gives us a whole new baseline to work with. This does not change the refraction. This does not change the refractive error, but it changes the clarity of vision through it. And when we improve the acuity, we improve the contrast sensitivity. Now we're able to actually improve the depth perception as well. So, how can we actually apply this in the office? How do we actually, see the patients and know what to do with them? Well, let's classify it first. There's about 4 different ways that we can classify this perceptual learning. First is in vision restoration. The amblyopes that maybe never had their vision, maybe it just never developed the right way. Maybe there's a pathology that happened where they have lost their vision. And so this vision restoration, this is a way for us to be able to recover something that was lost or maybe that they never even had. Now we have vision enhancement. These are the patients with the refractive errors, your myopes, your presbyopes, patients that just simply want to see better without depending on glasses, contacts, or not being as dependent on those kinds of things. Then we have the neuroadaptive supports. This is your contrast sensitivity. This is your night blindness. This is your post-refractive, blur, even if we're seeing 20/20. This is a quality of vision type of area. And then lastly, the vision optimization. Take the A's and make them A pluses, and making it so that we're improving contrast sensitivity and vision efficiency and processing for athletes, military, those kinds of things. All of these programs are different because we're targeting different neurons. Again, the blur caused in an amblyopia is different than a blur caused from glare driving at night. And so because those are different types of blur, those are different type of neurons, and these programs are tailored to address those specific neurons affecting that specific type of blur. And so, how do we find the right patient? First, how do they see when you're doing your refraction? Are they unable to see well, even with the best type of glasses we could possibly give them? Well, then we're probably dealing with someone that either has amblyopia or a pathology. If the best that we can do with the refraction still does not bring them to 20/20, they probably have one of these things caused by 1,000 different types of problems. Then what about the low contrast sensitivities? People who have good acuity, they read 20/20, and yet they're coming to you and saying they can't see. They can't see driving at night. They can't see this. They can't see that. And you measure them in the office and they seem like they're good. They may even be emmetropic. They may not have a refraction, but they're still having these quality of life complaints. They can be from post LASIK, post cataract surgery, or some people are just simply sensitive to that. And then, of course, the fun ones, the glasses haters. The people who have a little bit of refractive error but do not want to wear glasses, don't want to wear contacts. Patient, that says they can't see driving at night. You give them glasses, they say they won't wear their glasses. And so the thing is with these patients, 2 lines of improvements in their uncorrected vision can have a massive impact on their quality of vision, their quality of life, and will make them much more happy and much more easy to deal with. Those post-LASIK patients that were told they never need glasses again and they're starting to lose it, they are absolutely in this category of people that do not want to get back into glasses. And the thing about each of these is I know these patients are in every single one of your practices. These are not new patients out there. This is not a subset or a subgenre of patients that you have. This is people you are seeing literally every single day. And so we can make all of their lives better. The treatment process, really in two parts, the in-office portion where we're identifying the patient, we're writing them this prescription to do this perceptual learning. And, we build the patient, we add them to the system, and then we enter the baseline exam data. And then phase two is them. They go at home, they do the training, and they're coming back into you for mid-program follow-ups, and an end of program exam just to make sure that everything is there. These exams are really just acuity checks, significantly less time even than a contact lens check or a glasses check. The types of tests that we want to do here are pretty, again, standard fare, refraction and cover tests and these kinds of things. The one that's a little bit different is the contrast sensitivity. So why do we care about contrast sensitivity? It's the ability to distinguish an object from a similar background. That's the entire basis of what we're trying to talk about here with the contrast sensitivity function. Um, Acuity is a great measurable test that we're very familiar with, but contrast sensitivity actually simulates the real world a little bit better. And it may even be considered a better version, a better measure of vision quality. If we're talking about what normal vision is, and then someone who has reduced contrast sensitivity and a terrible glare, I would take, a line or two less of sharpness to be able to see those stairs more comfortably versus that person on the right. And even emmetropic patients can have great visual acuity, but still suffer from low contrast sensitivity. And just simply looking at acuity doesn't solve the problem and it doesn't identify the patient. It doesn't make their lives easier. And so, doing a contrast sensitivity test, we can diagnose several eye diseases as well, because a lot of times in these ocular diseases, contrast sensitivity happens before the acuity loss. So there's a lot of help to be done here by being able to measure contrast sensitivity, and again, being able to look at the different spatial frequencies to give us that graph, so it's not just a single point, gives us even more information. And so here's a few ways that you can measure contrast sensitivity. If you're able to find one of these sine wave function graphs, it's big and bulky and silly looking, but man, this makes it easy. It has all five spatial frequencies already right there, and it's a very quick, easy, just, tell me what number you can see. If you want to go a little fancier or have some little bit different stuff, you have the vision analyzer, the vector vision. One thing that I would avoid is the Pelly-Robinson chart or similar charts to this, because it really only measures a single spatial frequency. It only gives us a single portion of that graph. It doesn't give us the whole picture. Better than nothing, sure, but certainly does not give us the whole picture and is harder to be able to measure improvement when it's just one point that we're actually measuring against. So when we're talking about this perceptual learning, let's look at the inclusion criteria. Who is this for? Well, first off, they need to be motivated. This is some time. This is training. This is, 30 or 40 sessions, each one 30 or 40 minutes over the course of a couple months. This is taking piano or golf lessons for 3 months. Um, Typically, we expect age 9 and up to do well with this. Below that, it's not that they can't do it, but if you're able to tell a 6-year-old to sit still for 30 minutes and answer one or two questions, you can't. Cognitive intact, they need to understand what we're trying to do and be able to make the right choices. And of course, their vision must be stable. We can't have fluctuating vision. And they have the access to a computer. My mom lives in the middle of nowhere, Nebraska, and does not have internet. I don't know how she survives, but she cannot do this. And so that's a me problem, but all the same, it may be your patient's problems as well. The exclusion criteria, who we can not do this for, people with unstable vision. If their vision's fluctuating a lot, we really need to stabilize that first. You don't jump out of a car while it's still moving. We want to make sure that we're in the right place before we start getting their baseline information. This is an interesting one. Their eye deviation, if it exceeds 8 prism diopters, this is interesting because imagine if you have an esotropic amblyope and you're trying to improve their amblyopia, you're trying to improve acuity in that amblyopic eye, and you succeed. Well, if you did the improvement in acuity without improving the actual eye turn, well, now you're left with two eyes that can see well looking in two different directions, which causes diplopia. This eye deviation, this is actually a product of the training working too well. And so you want to make sure you address the turn before you address the acuity. Epilepsy, we're showing alternating targets. You always just want to be cautious of that. And then people who have significant ADHD, right along there with trying to have a 6-year-old sit down for 30 minutes to do anything. And so some additional inclusion criteria for amblyopia specifically. You want their acuity to be at least good enough that they can identify the targets. You again don't want their, in particular for the strabismics, not to have their eye deviation greater than 8 prism diopters. You want to make sure that they're fully corrected in their glasses. And then right here, when we're checking the acuity, there's a large jump from 2100 to 200. I don't know if you guys have ever really thought much about that. But there's only so much we can work with improvement in that range. And so you want to make sure you have an appropriate way to measure the acuity. And so a low vision chart right here may actually have more values in between 2100 and 200 that we can use to better track progress for these patients that have a little bit more severe deep amblyopia. During the actual exam itself, remember to do the cover tests. Remember to get your baseline acuities, stereopsis, fusion, those kinds of things. Prescribe the full correction. They're going to be wearing the glasses, throughout the day and during the training. They want to be fully corrected at all times. And if there's aniso, go ahead and do contacts. Go ahead and put a contact in that one eye. Um, During the training, they are doing this one eye at a time, so we do occlude the dominant eye, and you want to make sure they keep their eyes open. You don't want them squinching their eyes, and you want to plan for 40 sessions. However, you may end up doing both, and you want to do these at the end points of this. You want to be able to check every 20 sessions, 40 sessions, and then you may need more depending on how the improvement is going. Keep going until they stop getting better. And at the end point, again, checking acuity, stereopsis, and fusion, contrast sensitivity, those are all going to show improvements at the end of the training. For pathologies, low vision. You want again the best corrected acuity to be better than 2200 because you want them to be able to identify the target. Their vision again should be stable, very important in pathologies. You want to make sure that it's a central vision loss that we're trying to improve and not peripheral vision. We're not working on the peripheral neurons in this case. If they have bilateral poor vision, we can do binocular training as long as it's equal, and then do monocular training if we need to afterwards. For some of these pathology patients, maybe you want to do a little bit of a demo of the test first to see if they can actually handle it. Sometimes these patients, especially if they're a little more elderly, can struggle with being able to keep up with these tests. So you want to just make sure you do a test on them first before you get too deep into it. During the training, it's really a lot of the same considerations as in amblyopia. More training sessions may be required, 40 to 60. And at the end, you want to be checking the best visual acuity. You want to be checking the contrast sensitivity, at both far away and up close. And you really just keep doing this until you get the improvements to come to an end. Really, I know we only talked about a few of the pathologies that are out there, but you can try it with any pathology. Again, we're working on the brain. This is something very different, very unique. It's not restricted to any sort of ocular pathology. If the brain can help contribute to vision universally across the board, we can try this with any pathology that we feel comfortable with. So I welcome you to try it and see how it helps your patients. For the post-LASIK low myopes, these are people that are trying to improve their uncorrected distance vision. It's most successful when we have less than 1 diopter of refractive error. And but you can also do this with patients with poor contrast sensitivity, a lot of glare, aberrations, those kinds of things. And it can be emmetropic patients as well. They don't need to be have a refractive error if they're having severe night driving issues. One thing you really want to be careful about is managing the expectations. These patients basically will still see clearer with correction. A clear image on the retina means you don't even have to rely on using these quote unquote deficient neurons. So really do keep in mind that we have to manage the expectations that glasses are still going to help. This is why it does not take away from the glasses portion of my office. Um, Now, during the exam, again, we're trying to improve the distance acuity. And so just remembering this patient doesn't want glasses. They don't want contacts, or at the very least, they want to be less dependent on these things. So you want to make sure you have your baseline acuities and refractions uncorrected at the beginning. And then, depth perception, contrast sensitivity are certainly optional. During the test, they will be without correction, or there's a chance that they will receive a low training glasses prescription. These are very mild prescription to basically the algorithm will say that it will help if we ease them into this as steps in the program. And so keep in mind that that may be something that they do. Training sessions, about 30, follow up halfway through, and then again at the end. And at the end, just check their uncorrected acuity, see how it works. Contrast sensitivity if you're able to as just an extra measuring point. Presbyopia going along with the refractives. We're trying to improve their near vision, so make sure that they have near vision that they're trying to improve. Make sure they're presbyopic. Make sure that their ads aren't too high. I mentioned before, this covers about a diopter of prescription. That includes this as well. And so if we're talking about someone who has a 2.5 ad, we're probably going to bring them down to a 1.5 ad, which may still make them dependent on reading glasses or bifocals or whatever. So you want to make sure you don't go too far in this and managing, again, the expectations. And this is a 2 to 3 month program that's slowly improving near acuity. Sometimes they don't feel that improvement. And I know that our presbyopic patients aren't always known for their patience. So make sure that they have their expectations managed. Make sure they're aware that things will still be easier if they are wearing their bifocals and progressives and multifocal lenses. However, this is something that will reduce their dependency on them. During the exam, again, keep in mind what we're trying to do, near vision. So make sure we have near acuities and refraction. I highly recommend measuring the accommodation. It's very cool being able to see someone's PRA go from a 1 to a 2.5. And then, the stereopsis, contrast sensitivity, of course, are things that we can look at as well. Training portion is going to be very similar to low myope, where they can have some training glasses, and following up is very similar. And again, at the end point, measuring their acuity at near, measuring their accommodation. Sometimes they don't feel the difference, and so being able to have another measuring point is very, very helpful. And then, I actually had a patient who complained initially that their arms were not long enough, and then they still complained at the end of it because, they were still seeing blurry when they held it right up on their nose, showing them that they were able to hold it up to their nose was the win on that one. But for cataracts, post cataracts, these are a lot of times unhappy patients. These are patients that were promised not to need glasses, promised that cataracts were going to make their lives perfect, and now they have still reduced acuity or contrast sensitivity. They may be emmetropic, but they still have complaints. Maybe they have problems with neuroadaptation with multifocals, monovision, those kinds of things. So remember the goal. We're trying to improve their vision, sometimes with, sometimes without glasses. We do go through the training sessions. We get to our testing the acuity, the contrast sensitivity. Really big on this. Ask about the lifestyle. Ask about the quality of life. Those are where you're going to get the biggest signs of true improvement. And then lastly, sports vision. Sports vision, we're trying to take the A's to the A plus, and we're not expecting as much of an improvement. These are already 20/20 or better individuals. So we're looking at an average of one line of improvements, 50% improvement in contrast sensitivity. Really save this for your super athletes, your military, your specialty jobs that may need high visual demands. Again, shorter sessions with the 30, and they can train with their habitual correction and really look at the contrast sensitivity. It's going to be hard to mark an improvement if you're just measuring acuity, but if you're measuring contrast sensitivity as well, you're going to show a lot more improvement there if than a patient going from 2020 to 2020 plus two. This is kind of my last little bit where we have an example of a patient. is seen in office where they are myopic. They wanted to do the low myopia program, and you can see the acuities down here starting are 20/80 and 20/30, respectively, right eye, left eye. This is what it looks like to track the progress. The very bottom line, you can see it goes from light blue to green to red. That is changing the size of the stimulus, getting smaller and smaller, and you can see the degrees that the stimulus are at as well, identifying different neurons that it's going through. This patient went through 22 sessions, and over that 22 sessions, we had in 3 months, we had an improvement of an acuity of all the way to 20/40 and then 20/20. And so very, very cool to again see that one line improvement on the left, three-line improvement on the right. That makes a difference. And so really my summary, perceptual learning gives a solution for problems for patients that a lot of times we couldn't address and really focusing on improving quality of life more so than a lot of other things. Home-based therapy, patients don't have to come into the office. It's minimal office time. There's no side effects, no risks or long-term negative effects with this when we're teaching the brain to do more things. Cost, there's no equipment, materials, surgical procedures, very easy for office and patients to implement. There's a lot of strong study support still coming out there, and long longevity, with a 5-year study out there. And it can be used in combination with other things. We can still have patients wear glasses, wear contacts. We can still treat the ocular disease. We still want to treat the ocular disease. But this is the only thing that's improving things by addressing the back part of the vision. And so there we go. That is brain training for you guys.